Hi, good evening to all the participants. Today we have the topic of weaning from the ventilator in ICU Webinar Series, which is being organized by ICS and Indian Chess Society. I would like to first of all thank Dr. Sandeep Salve, Dr. Amita Nene, and Dr. Rajadhar for giving us this opportunity to do this series, and also would like to thank academic partner CIPLA, whose technical expertise and help has helped us to give this web series. Today we're going to talk about ventilator weaning, the art behind the science, and we have a very eminent speaker called Dr. Kushav Bajan, who is from Hinduja Hospital. He is the head of the emergency department there. We all know that we ventilate patients so many times, but when it comes to taking them off the ventilator, there are many problems which we face on a regular basis. The art of taking the patient off from the ventilator involves three steps mainly. One is the patient readiness testing to find out whether he's ready to be weaned. And the second process is obviously the weaning itself. And the third process is taking off the tube itself, which means the actual extubation. And all these steps may have various components to decide. There are some physiological components, there are some clinical components, and Dr. Kushav Bajan is going to discuss all of them. So can we have Dr. Kushav Bajan to start his talk? We also have an eminent panelist called Dr. Prabhu Desai from Mumbai, Dr. Sumita Agarwal from Jodhpur, Dr. K.K. Sharma from Jaipur, and Dr. Richa Mittal from Mumbai itself. So can we start with Dr. Kushav Bajan?
Hello, friends. I'm really privileged to be back with you all for the Indian Chess Society, and I really thank Dr. Amita Nene for having me over again. It's a pleasure to be with you all and discuss views and learn from each other. Today, I'm going to talk about ventilator weaning, and the reason why I have given this topic a heading, the art behind the science, will be explained in the next 20-25 minutes. Mechanical ventilation is one of the most important support therapy in critically ill patients with sepsis, shock, stroke, and cardiorespiratory failure. With each passing day, the complications of mechanical ventilation mount exponentially. It is thus imperative for us to wean them as early and as efficiently and appropriately as possible. Failure to wean can lead these patients to be tracheostomized and put on long-term home CPAP and BiPAP. Weaning is a scientific strategy which is performed with an art of selecting the right patient at the right time and with the right mode. Unfortunately, 20 to 30% of our mechanically ventilated patients fail their first attempt at weaning, especially if ventilated for more than 24 hours. More than 40% of the total duration of mechanical ventilation is also spent in the process of weaning, making it such an important topic. Weaning from mechanical ventilation and extubation are though two separate entities, and we are going to look at that towards the end of the talk. So, a little bit on the definition. There is a difference between weaning and liberation. Weaning is a gradual process in which we withdraw the ventilatory support, finally leading to extubation, whereas liberation is a direct and a sudden withdrawal of the ventilatory support leading to extubation immediately. So liberation is usually done for patients who are ventilated post-operatively and are doing fine, whereas weaning would be a gradual process in patients with COPD, ARDS, sepsis, etc. So what if we delay the liberation or the weaning? I can be as complacent and as slow and as cautious in trying to wean the patient off. But as I mentioned, with every passing day, the chances of ventilator-associated pneumonias, ventilator-induced lung injury, prolonged sedation, problems of GI bleed, DVT, and the list goes on. And along with this, an obvious increase in the length of stay and the length and the cost involved in these patients. So let me swing to the other side and try to extubate everyone prematurely. So what are the risks of premature extubation? It is loss of airway protection and therefore aspiration, which is the most deadly thing to happen in the ICU. Gas exchange failure leading to even cerebral dysfunction, sympathetic discharge causing cardiovascular stress, muscle fatigue and respiratory acidosis leading to reintubation, and finally increased morbidity and mortality. So I need to find a balance between premature extubation and delayed extubation. So weaning basically, if we understand, depends upon three main factors. One is the respiratory muscle strength with which the patient can wean. And against that, on the other side of the balance is the load against which the respiratory muscles have to work. And the top of this or the parent of this is the respiratory drive. When all three are within a balanced range, then weaning would be possible. And this is a nice pictorial. On the left, you can see that the demand is high, the pressure load and the ventilatory load is high because of a decreased compliance, increased resistance, increased oxygen consumption, carbon dioxide production, and these patients are mechanically ventilated either partially or on total support by a controlled mechanical ventilatory mode. But when the capabilities improve, the neural drive improves, the muscle strengths and the endurance improve, the diaphragm gets better, and the increasing reserve happens, then we would probably improve. This patient is improving enough to have a tolerable load, and spontaneous ventilation or weaning can be undertaken. So this is very important for us to understand. Just one more terminology here. What is the difference between difficult weaning and prolonged mechanical ventilation or prolonged weaning? So difficult weaning is a term when patients who fail weaning require up to 3 spontaneous breathing trials or up to 7 days from the first spontaneous breathing trial to achieve a successful weaning. So up to 1 week is actually in practice thought to be difficult weaning. And prolonged mechanical ventilation or prolonged weaning is defined otherwise as those patients who need mechanical ventilation for more than 6 hours per day for more than 21 consecutive days. So up to 1 week is difficult weaning, and 3 weeks and beyond is prolonged weaning. So these terms are pretty important for us to know and not be used very loosely. So now that brings me to the question, when should I decide to wean a patient of a mechanical ventilation? And I would love to divide this answer into 3 main categories or 3 main pillars. The most important, that is A, is the primary reason for ventilation should be corrected. For example, if the patient was intubated and ventilated for a pneumonia, the pneumonia has to start getting better. If it was for ARDS, that has to get better. If the patient was ventilated for just a surgery, then that obviously the cause is better, and therefore we would think about weaning. Once we have done the A part, we need to make sure that the patient is hemodynamically stable. I wouldn't say hemodynamically normal, but even a certain amount of inotropes, vasopressors is allowed, but it should not be having an increasing trend. And then finally, the parameters which we all look for are the ways in which we manage to know the oxygenation and the ventilation of the patient, that when we extubate or wean the patient off, would they be able to sustain themselves on their own? So looking at A, the correction of the primary cause, I already mentioned, it depends upon what caused the mechanical ventilation in the first place. And hemodynamically stable, I mentioned, this is very important. Normally, 40% of cardiac output is required by the respiratory system to perform its functions. In cases of respiratory failure, the work of breathing is high, and more than 40% of cardiac output is driven to the respiratory system. And therefore, if you wean them when they are hemodynamically unstable, there would be no cardiac output reaching the brain or the kidneys, and the patient will do worse. And therefore, we must make sure that the patient is reasonably hemodynamically stable before we entertain the thought of weaning. And then there are some other general measures in the ICU that we must follow, like correcting the acid-base disorder, correcting the electrolytes, because phosphatemia and hypokalemia and hypomagnesemia can worsen the chances of weaning success. avoiding volume overload, which is going to be discussed at the end of this lecture, adequate mental status, which would help us to involve this patient in breathing well and then for extubation, and avoiding malnutrition, because a good protein intake is extremely important for the muscles in patients who are long-term on a mechanical ventilation. Coming to the C part, and that is the adequate oxygenation and ventilation. Here we are trying to see the balance between the muscle strength and the load. And there are various parameters which we honestly don't follow, but this is called as the respiratory mechanics, which we check before we undertake a process of spontaneous breathing trial. The tidal volume, as seen, should be more than 4 mils per kg. The vital capacity should be more than 6 and less than 10. A maximum voluntary ventilation should be MMV, should be less than 10. There could be a crop index which can be done, and that, if more than 13, has a high likelihood of ventilatory withdrawal success. But the most favorite that we follow is the rapid shallow breathing index. That is, we are looking at the tidal volume and the respiratory rate. For example, the ratio should be 10 times of the respiratory rate. So if my respiratory rate is 30 and my tidal volume is 400, then the chances of this patient of weaning successfully are higher. But if my respiratory rate is still 30 and my tidal volume, as per the mechanics, is 200, then the chances of weaning failure are much higher. This is what is meant by rapid shallow breathing index. And this is what we usually follow besides all the others that I mentioned earlier. So now I know that I need to wean a patient when they are hemodynamically stable, when the cause is treated, and when they fulfill their parameters of ventilation and oxygenation. And now I need to take the next step, and that is, how do I wean these patients? So the preferred modes there has been that there is a significant heterogeneity in the population of mechanical ventilation, and there would be no one mode better than the other. So you cannot compare somebody whom you are weaning from ARDS as against somebody whom you are weaning against a COPD patient. Similarly, if somebody is ventilated for less than 3 days, would wean better than somebody who is beyond 3 days. So the mode might depend upon the population that we are catering to. And there is no magic bullet mode of weaning, and a difficult to wean patient will remain difficult despite whichever mode you might use. So what are the modes that have been advocated in trying to wean somebody? That is a patient, a T-piece, a pressure support, an SIMV which is PASS. But there's lots of literature in the difficult weaning patient where they are extubated to HFNO and also NIV. So HFNO, there are some recent trials which said that if you extubate them to HFNO, especially post-COVID, we have got lots of literature, and this is a very good aid in helping a difficult weaning patient. Or sometimes we might use a proportional assist ventilation, and that's another proven mode of weaning. Or then some protocol-driven or directed weaning measures, computerized measures, closed-loop systems, and automatic tube compensation systems can be used. But by and large, we, on a daily basis, are struggling between a T-piece and a pressure support ventilation, almost never an SIMV. And unfortunately, both these are clubbed as an SBT. So you might use a spontaneous breathing trial, which is a direct T-piece, but you might add some CPAP or pressure support, and it is still called a SBT for practical purposes. So this SBT, as I mentioned earlier, could be a direct T-piece, or it could be a low-level pressure support, or it could be a low-level CPAP. And sometimes we can use a flow trigger instead of a pressure trigger to help these patients to wean faster. We may use protocolized spontaneous breathing trial, and this is a graph taken from one of the chapters on weaning, which I have written in the critical care books. So the first breathing trial, the second trial, the third trial, and either if they are successful, we would extubate them. But if not, then we may facilitate them with NIV. It's not mentioned HFNO because this was before the COVID era. and then after the third, it becomes a difficult weaning, and therefore we might need some permanent cures. We might even need to put them on long-term NIVs or even do a tracheostomy early in these patients. Now for COPDs, we know that it is a bit difficult after about 72 hours. And if they have not been extubated within 72 hours of initiating the spontaneous breathing trial, they have failed. And post-extubation, sometimes they have respiratory failure. So there is enough evidence to show in a COPD hypercapnic patient that use of NIV can prevent further worsening. But as a treatment, there is inconclusive evidence. So it again depends upon the type of patient, the type of disease, and the number of days the patient has been on mechanical ventilation. Very important every day is to understand whenever we try a spontaneous breathing trial, we need to understand when is the patient failing the weaning, because prolonging the spontaneous breathing trial to more than half an hour, 1 hour or 2 hours can be deleterious. And again, as I mentioned, can cause a lot of load on the cardiorespiratory cerebral system. So if the heart rate goes beyond 35, if it was beginning at something like 25, 30 for more than 5 minutes, or a heart rate which is more than 120 to 140, saturations less than 90, systolic blood pressure which is high, which would indicate hypercarbia, or low, obviously, agitation, diaphoresis, and some new cardiac arrhythmias would be all indicative of weaning failure. But what I feel is the best method is to look at the patient, see whether their accessory muscles are being used, see whether they are comfortable or not, talk to the patient, encourage them to wean better and breathe better spontaneously. So I think that bedside maneuver is one of the best ways of knowing whether the weaning is successful or not. And if they do fail, then there are lots of causes which I mentioned earlier. It could be a cardiac load, it could be a pulmonary load, it could be central system which is depressed, or there could be electrolyte imbalances, especially hypophosphatemia, or there could be some sleep deprivation and hallucinations and delusions which might interfere with our weaning strategy, or for that matter, even a poor nutrition in a long-term ventilated patient would be extremely deleterious. So if there is weaning failure, then we might have to give them rest for 24 hours after 3 trials, correct the causes, retry weaning after that, retry with gradual modes and use some other modes, especially HFNO, and then tracheostomy if they still don't get better. This is a newer concept relatively new concept which has come up during the weaning efforts, and that is called as WIPO, weaning induced pulmonary edema. And as you can see, the effects of positive pressure on the heart are so different that finally, when you suddenly change from positive pressure to negative pressure, there would be a decrease in the intrathoracic pressure, there would be an increase in the left ventricular afterload, there would be an increase in systemic venous return, and the entire chart is a matrix which actually leads to pulmonary edema when you suddenly switch them over from a positive pressure to a negative pressure self-ventilatory mode or method. And therefore, this is an important thing to be considered when we are weaning somebody off a ventilator, especially in post-CABG cases, or patients who have been intubated for cardiogenic shock, or patients who have a weak heart from sepsis, or cor pulmonale from COPD, etc. So what is recommended is for WIPO, before a spontaneous breathing trial, we must do an ECG, we can do an echo, we can do a lung focus, which we do all the time because the echo may not be easy. So we can just quickly look at the lung for any B lines. We can do biomarkers for cardiac dysfunction, and sometimes we do a plasma protein and hemoglobin concentration if the reports are available as a point of care, which would tell us the fluid status of the patient. And once we have confirmed that there is no respiratory problem or there is no neurological problem and it's a pure clinical cardiac problem, then we need to circumvent and treat that depending upon whether it's a systolic dysfunction, a diastolic dysfunction, or a COPD with hypertension, or a hypertrophic cardiomyopathy. So beta blockers and diuretics are used, and this is a reasonably new concept. So sometimes when we suspect this, we just do a very quick focus on spontaneous breathing trial, and we even give them 20 milligrams of a diuretic before extubation along with a painkiller, and that has shown very, very good results in weaning somebody off and extubating them. Various other strategies that can be used for successful weaning, as I mentioned earlier, could be a proportional assist ventilation, a protocolized weaning, automated tube compensations, computer-driven closed loops, spontaneous awakening trial. So sedation holidays are important in those who are difficult to wean, and awakening and breathing control, or ABC, are the terms you will be looking at and listening to whenever you talk about weaning. So this is a nice protocol. Whenever we are trying to wean, we need to have a PaO2 FiO2 ratio more than 200, a PEEP less than 5, intact airway reflexes, and no need for continuous infusions of vasopressors or inotropes, at least not increasing. Then we can try a rapid shallow breathing index checking on them, or a respiratory mechanics to be performed. If it is more than 100 or 105, then we can wean these patients off and even extubate them. If it is less than 100, then we can try a daily spontaneous breathing trial. Low levels of CPAP can be added. Low levels of pressure support can be added. And if it is very less, between 10 to 120 minutes, we can give a spontaneous breathing trial. So some prefer giving only a short 30 minutes, and some go on for almost 2 hours. But we need to monitor the patient and look for signs of failure or not on the TPs, and these have been discussed earlier. If there are none of these signs or very few of these, then we can extubate this patient. But if there are signs of distress, then we need to have an assisted pressure support, ventilation intermittently with the TPs, and then go to the difficult weaning protocol. At every stage, when we wean the patient off, we need to know that we need to extubate these patients unless they have been tracheostomized early. So the assessment for readiness of weaning should also be considered for readiness to extubate. And the three, so this is a nice diagram which would tell you that the heart should be good, the oxygenation should be good, and the pulmonary function should be good. But this is all desirable. Many a times our patients have some good and some bad in them, of all these three. And the 3 C's, that is the cough, reflex should be good, clean airways should be there, and clear on auscultation, good conscious level, and stable metabolic status. So this is the desirable way of readiness, but many a times we have 50% of this and we still try to wean these patients off, because every day we have more and more problems if we don't wean them. Extubation failure is usually due to an obstruction because of poor neurological conscious level of the patient, increased respiratory secretions, sometimes an airway trauma which has happened because of a long-term endotracheal tube and there is laryngeal edema, or loss of positive pressure suddenly going into negative pressure and causing VPO. So we might, it's advocated in some protocols that a laryngeal edema could be one of the main reasons for extubation failure. We're not talking of weaning here. We've decided to wean and we have now extubated, and the patient could have laryngeal edema, and you are in a fix again wanting re-intubation, and you cannot because the edema is too much. So the risk of laryngeal edema could be an initial traumatic intubation, an intubation which is there for more than a week, large endotracheal tubes. Having said that, 8 and 8.5 are all that we always use, never small size, re-intubated after unplanned extubation, or the cuff pressure is kept too high. Cuff leak test is usually done, and if the cuff leak test, there should be a leak, otherwise it means that the larynx is actually falling on the endotracheal tube. So when you do a SBT or before you do it, you must do a cuff leak test, and if it is positive, then you might extubate. There are some trials which I would like to discuss before I end here, and this is a trial called as Reconnect trial, where reconnecting to a mechanical ventilation for 1 hour after a successful spontaneous breathing trial, giving them rest, reduces the reintubation in critically ill patients. It's a multi-center randomized control trial, and it actually showed significantly reducing the rate of reintubation within 48 hours. So maybe you can just give them a rest for 1 hour. The other study which I would like to discuss is the BREATHE study, in which extubation to NIV for difficult to wean patients was undertaken. And here it showed, unfortunately, that it did not show that spontaneous breathing trial during mechanical ventilation, early extubation to NIV did not reduce the time to complete liberation. So what they said is, even if you extubate early and put them on NIV, the final liberation of the ventilator, they may need reintubation, etc., and that was not good. But a secondary outcome which was seen had some benefits here, and it said that there was reduced antibiotic usage, reduced sedation requirements, and reduced time in the ICU, and therefore this may be looked at even after this JAMA article in 2018. And then one more study which actually looked at the effect of pressure support versus TPs alone during a spontaneous breathing trial on successful extubations among patients receiving mechanical ventilation in 2019, again in JAMA, called as the SUBIRA trial. And here it supports a use of shorter, less demanding ventilatory strategies. And that means that if we used a spontaneous breathing trial consisting of a 30-minute pressure support on that compared to a 2 hours TPs trial, it had higher rates of successful extubation. So there are lots of studies and data which is still out, and the jury is not out, and we need to understand that we have a long way to cover understanding weaning. And I would end here by saying a thought can change the world, and so weaning should be thought of in all mechanically ventilated patients as soon as possible to change the patient's outcome in a positive direction. And I thank you all.
Thank you, Dr. Kushra, for such an excellent talk. Do we have the panelists present?
Yes, sir.
So can I present the first, Prabhu Desai? He is a consultant at Leelavati Hospital and a very dear friend of mine for a very long time. We've known each other for last, I think, 40 years, actually. And then we have Dr. Sumita. Dr. Sumita Agrawal is from Jodhpur, and she is a consultant at Medipulse Hospital, Jodhpur. And we have the next panelist as Dr. K.K. Sharma, who is from Jaipur Eternal Hospital. And we also have Dr. Richa, who is from Reliance Foundation Hospital, Mumbai. Do we have all of them?
Yes.
Okay. So can I start the panel discussion? Dr. Prabhu Desai?
Yeah.
Can you hear me?
Yes, yes.
Yeah. So after we've ventilated the patient, what would burn them off quickly? What are the hazards of prolonged mechanical ventilation?
Yeah, I think prolonged mechanical ventilation have many hazards actually. One is, the first is ventilator-associated lung injuries, barotrauma, volume trauma, etc. It also, patients are vulnerable for infection like ventilator-associated pneumonia. So these are two important things besides when you give oxygen for a prolonged period of time on mechanical ventilator with under pressure, oxygen toxicity, then many prolonged ventilation patients have got a respiratory muscle dysfunction, especially diaphragmatic dysfunction. This is also very sound reason for a difficult weaning. Okay. Then say psychological dependence on the ventilator, airway injury. So these are the all, and also the prolonged ventilator leads to difficulties in weaning also. So as you ventilator therapy continues for a long period of time, the weaning also becomes difficult. So these are all many complications you can say of a prolonged mechanical ventilation.
Yeah, thank you, Dr. Prabhu Desai. So Dr. Sumita, would you consider trying weaning in a patient who's on mechanical? When would you consider that? When would you decide that this patient is now fit enough to be weaned off?
Right. So, as I said earlier, like there are three steps of weaning. First of all, you would like to do a readiness testing. Then you would be try the weaning and then extubate. So, readiness testing, that is, we decide when is the patient ready to wean, has got certain objective criteria. Some of these criteria were discussed in the presentation as well. I think the first and foremost important is that the reason for which the patient was intubated, the reason for that respiratory failure has reversed itself. A second would be that the patient has maintaining adequate oxygenation. And by adequate oxygenation, we mean that the patient is having a saturation of more than 90% with an FiO2 requirement of less than 40 with a PEEP of less than 5. And in certain cases, we can accept a higher PEEP, like an obese patient or a patient having ascites. And in certain cases of chronic hypoxia, you may accept a lower oxygen level, but adequate oxygenation should be maintained. Other criteria, as mentioned earlier, hemodynamic stability, like a mean arterial pressure of more than 60 or a systolic BP of more than 90 and less than 180, or if the patient is on low vasopressor support. And then another important point is the arterial pH. pH of more than 7.25 should have been achieved. Patient should be able to take spontaneous breaths. Other important criteria would be that the patient is awake or easily arousable at least. And then there are certain criteria which may be considered in certain patients, like your hemoglobin level is adequate of more than 7, and your core temperature, like fever, is not there. Because again, if the patient is having persistent fever, then again, difficulty in weaning would be there. So once these objective criteria are fulfilled, this patient then is in the next step, going from the next step from readiness testing of to trying the weaning criteria itself.
Thank you, Dr. Samita. So, Dr. K.K. Sharma, when we are using the trial for weaning, we mainly do the spontaneous breathing trial. So, when you try PSV, what settings should be kept to assess successful weaning?
So, sir, as we are aware, PSV is one of the mode for spontaneous breathing trial, apart from TPs. So, in PSV, what happens? The patient who is decide about the length, flow, and all the breaths are taken by the patient. So, three important settings are there when you are using a PSV. First is PEEP. So, we usually start SBT when the PEEP is around 5 to 8 centimeter of S2. Second is pressure support or the driving pressure. Usually we start by keeping it in around 8 to 14 centimeter H2O. And third is FiO2. So these are the only three settings which you usually do while using PSV in these patients. And what happens when you start the patient with these settings, and the maintenance validation is derived by patient's respiratory rate and tidal volume. So after watching the patient for a few minutes, putting on these settings, if the patient is tolerating this breathing trial well, then we gradually decrease this pressure support by 2 centimeter H2O. And if, say, after 3 hours, patient is maintaining well, then we further decide about weaning or extubating the patient.
Thank you, Dr. Sharma. So, like Dr. Kushav mentioned, that there are many ways of weaning the patient. Dr. Richa, have you ever used the ZEEP trial for weaning? ZEEP, ZEEP. And if you use them, why do you use them?
Okay, so what exactly are ZEEP trials? They are basically where we are trying to simulate the physiological condition that would be post-extubation for any patient. So we are trying to simulate that. And what we actually do in these ZEEP trials, we are giving 0 PEEP and 0 pressure support. But then it is as good as TPs. And why we are doing it? The question comes that. And why is that so? Because when you are connected to the ventilator circuit, first of all, you're able to measure the expiratory tidal volume. You're able to calculate the minute ventilation of the patient during your SBT, during your spontaneous breathing trial. So that's a big advantage. Then you are not connecting again and again. So chances of infection are less. You're connected with the ventilator circuit. Another advantage is that the humidification is maintained while the patient is breathing spontaneously. And obviously, then there is always an advantage that the alarm settings are always there at the ventilator, and you'll be more prompt in connecting back to the previous setting because patients already connected to the ventilator circuit. So these are the advantages. Now coming to the second question, whether I have used it, to be honest, I have not used it, but I have used TPs, specifically TPs where I know we prefer pressure augmentation and pressure support ventilation while giving SBT. But TP is one condition where I genuinely use TPs more is when there is cardiogenic pulmonary edema was the cause of the intubation, and where I would like to give maybe a 1 or 2 hour of TP's trial so that I am able to let go of that therapeutic PEEP and judge exactly that how well the patient will do post extubation. So maybe that is one area where I would like to try this ZEEP trial. But yes, to be honest, I have not used this as of now.
May I just add a point on this, Dr. Bansal? Can I just add a point?
Yeah, sorry.
So as
Yeah,
Dr.
sure.
Richa,
No, why not?
Yeah, as Dr. Richa rightly said, this ZEEP trial is tried. ZEEP basically means zero PEEP. So this can be tried as an SBT, but the real ZEEP trial, which actually happened, was in neurosurgical patients where they had two arms of patients. One was zero PEEP and zero pressure support, and the other had +5 PEEP and +5 pressure support. And unfortunately or fortunately, they did not find much of a difference significantly in extubation in both these patients. So, as rightly mentioned, because of the tubings and the circuit, there is an added PEEP added to the patient's breathing efforts, and that is therefore +5 is considered to be that physiological PEEP. So that term also comes into the being. So just wanted to add that point.
So one point
sure,
that I would
agree
like
with
to
you.
make, sir, is that ZEEP, definitely that previously also people have used zero PEEP and previous like 10 years back also. And if you review the literature, they stimulate and they tell best the work of breathing, the effort of breathing, exactly like how it will be post-extubation period. So that is one way you can simulate the post-extubation. Whereas when it is seen with the pressure support ventilation, they try to underestimate the work of breathing of the patient because we are supplementing the pressure support. So we are actually augmenting the patient's inspiratory effort. So maybe just to simulate the physiological condition. Yes.
Yeah, but come to think of it, like Dr. Kashyap said, that there is zero pressure simply because the tube itself will cause a pressure of something like 4 to 5. And, if you have a pressure of 5 to counter that, then you've actually virtually put it as a 0, basically. Okay. So, Dr. Kashyap, what is pressure assist ventilation and how would it help in weaning?
So despite thinking of weaning on day one and thinking of every day that you want to get the patient off, and multiple modes have been tried over the last few decades, rather 2 or 3 decades. TPs versus pressure support have all been tried, and there's very little literature, as we had mentioned earlier, that one mode is better than the other. It's just the right selection of the patient. So a newer mode, a relatively newer mode called proportional assist ventilation. We are not very aware of using this mode often, but I've used it in a couple of patients. And what this does is the name itself says proportional assist ventilation. So it assists the patient's breathing, and it's only a proportion of the breathing that it will assist. So it's a very nice chart that the more the patient makes the effort, the less the ventilator will deliver. And the less the patient will actually make efforts, the more the ventilator will deliver. So this mode, definitely there is a adequate study in which proportional assist ventilation has been successful in weaning failure patients to successfully wean them if used appropriately. So it's if you look at a chart of work of breathing of the patient and work of breathing of the ventilator, as I said earlier, in pressure control or pressure support, it will be the same pressure will be delivered across the patient's effort. In volume control, there will be a rising increase in the volume control or the support given as the patient increases the support. But here in proportional assist, we are encouraging the patient to breathe more and more. And as the patient efforts improve for whatever reason, the condition is getting better, then the ventilator does less and less work. So that is the way proportional assist ventilation works. We lost you, sir. Yes, sir. We can hear you now.
Okay. So Dr. Prabhudasai, can I ask you the next question? What is the criteria of saying that the spontaneous breathing trial is successful now?
Well, Dr. Kushra really properly explained during his talk that when you consider for a spontaneous trial, how much you should wait. I think generally I prefer to wait for 30 to 35, 40 minutes rather than waiting for a prolonged period of time. But they say up to around 30 minutes to 2 hours, one can wait and basically observe the patient. This is a clinical observation. Like, for example, how the patient is breathing, his respiratory rate, shallow breathing, or adequately the respiratory rate is very important. Okay, then pulse, tachycardia is happening. Bradycardia will be more dangerous rather than a tachycardia. Little tachycardia will happen. Then the efforts for breathing, whatever he is taking, the labored breathing, okay, whether he is doing or not, blood pressure is stable or not. That's one important thing. So it's basically a clinical. Along with that is oxygenation, okay, and saturation. If you have, saturation, we can do on blood gas after some time to understand, okay, whether the PaO2 is sufficient. More than that, pH is adequately maintained or not. That's very important. He may have some amount of PCO2 high, especially I'm talking about COPD patient. But yes, the blood gases are also important. Then the patient is whether his sensorium, how is there, whether he's becoming drowsy or so. All these signs, which are all just clinical. So that's why the good intensivist or who is taking care over there, by just observing patient for a minute after half an hour of trial, he will give you the yes, go ahead with extubation. So this is the science is there, but it's more of art actually. What Kushra has said, that there is a good art in early extubation by understanding the patient's pulse over here. Okay, what sort of he's likely to have. Obviously, the other PaO2, FiO2, all those ratios, etc., and all that are important. Tidal volume, what patient is generating, or tidal volume multiplied by respiratory rate, all those calculations, everything is good, but it's just an observation of the best vital signs and the sensorium. Okay, we can make a decision about whether a spontaneous trial is successful or not.
I go with Dr. Prabhu's side. We are the old-timer intensivist who would just watch the patient, and we call it what is known as golden window of extubation, So if you miss that bus, then you've just delayed everything basically. So if the patient doesn't become tachypneic, if the patient doesn't become tachycardic, if the blood pressure doesn't go up and down, if the sensorium remains fine, if all of the parameters are looking good, then this is a patient who's actually successful past the SBT trial. So, Dr. Sumita, is there any method?
Even like sometimes agitations and anxiousness.
Exactly. Yeah. So, Dr. Sumita, can I ask you, is there any other mode which is better than SBT? The spontaneous breathing trial, like PSV or PAV? And if you think they are better, then can you give us some reasons for that?
Right. So as we discussed that pressure support ventilation is one of the best modes that you would try for breathing, for weaning. But the pressure support is a patient triggered and pressure targeted and flow cycle kind of ventilation. Now, many patients who are having either they are on prolonged ventilation or they're having other issues like muscular weakness or cardiogenic pulmonary edema, these patients may fail your trials on pressure support ventilation. They can have ventilator dysynchrony or their muscles are not strong enough to support that kind of low pressure system. In those cases, various other modes are available and should be tried so that continuous weaning trials can be given to these patients. One of the most discussed earlier by Dr. Kushra is proportional assist ventilation, and it is getting more commonly used now since we have got many successful trials of proportional assist ventilation where the ventilator gives its own pressures depending upon the patient's effort. So there are like meta-analysis available now on proportional assist ventilation where they've shown successful weaning, decreased length of ICU stay, decreased number of days on ventilator. Apart from that, various other newer modes are now available. One of them is like the adaptive support ventilation, where the pressure support again increases or decreases based on the patient monitored parameters, which decreases the work of breathing and decreases the autopeep that these patients have. Now, these kind of modes are especially useful in patients after thoracic surgeries. So, like if they are extramuscular, their muscle and the extrathoracic part is not working efficiently. So, as soon as they start working, depending upon that, the ventilator decreases, increases the pressure support. There are various other modes, like one of the modes is NAVA, neurologically assisted ventilator, where you insert a catheter into the esophagus just at the level of the diaphragm, and the ventilator itself detects the diaphragmatic contraction. And depending on the diaphragmatic contraction, the neurological signaling is depending upon that proportionally the ventilator adjusts how much pressure support has to be given. So the settings have to be made by the intensivist as to how much diaphragmatic contraction and how much the NAVA will then give assist to the patient. If the patient is not functioning, the diaphragm is not functioning very well, in those cases, the ventilator will itself give more ventilation. So, for this is especially helpful in patients who are on prolonged ventilation, having diaphragmatic weakness, or COPD patients, where again their muscle is weak, their diaphragm is weak enough. So, you are going to coordinate. So, the patient ventilator dysynchrony is not present in these kind of state, because the ventilator delivers once it senses that the diaphragm is contracting and how much the diaphragm is contracting. There are many other newer modes like the AI systems now available, the artificial intelligence. They are especially useful in post-operative patients. So you can just connect them to the artificial ventilator mode. And once the patient starts breathing spontaneously, like the sedation goes off and the patient is comfortable, so the ventilator itself assesses how much the patient is having, the frequency of breathing, what is the patient's tidal volume, what is the EtCO2, and it gives a modified SBT. And once the patient has successfully handle this modified SBT, it sends a message to the intensivist that yes, the patient is ready for your weaning trials now. So these are the most common newer modes available. A few modes more are like volume targeted pressure support. So if you're doing a standard pressure support, your volumes may vary. So for a patient who is having a lot of atelectasis, for those kind of patients, your volume may not be similar. Or patients having again muscle weakness, volumes may not be similar for each breath. And those cases, in those patients, they may be further prone to undergo more atelectasis. So you can have a volume targeted pressure support ventilation to help in giving a daily weaning trial to these patients. So I think these are the most newer modes which we can try for these weaning kind of patients. Yeah. So your audio.
You're muted, sir. Sir, you're muted.
So your audio is.
You're muted. You're muted. Yeah, better. Dr. Sumita, you made some very amazing points, and all these modes have been tried. The NAVA has been tried, especially for diaphragmatic weakness. None has been proven to be beneficial except PAV, but a very comprehensive list that you gave us. Thank you.
I think the most successful has been the proportional assist ventilation in the recent few years, apart from the pressure support ventilation. None of the other modes have actually proven to be very successful, but they are available and can be used for patients where we are having difficulty in weaning them.
Sure.
Yeah.
Dr. Bansal.
Okay. Can you hear me now?
Yes, sir.
Okay. So what I was trying to say is that the most of the newer ventilator will now come with AI assist and actually give a alarm to the intensivist that this patient is probably ready for weaning, and it's going to help them. Like RSBI comes already in some of the ventilators. You can see it on the screen, and they can tell you exactly what is happening. If it is more than 105, then you know that this patient is probably ready for weaning. So Dr. KK, when you try to take the tube out, sometimes the patient needs to be ventilated again very quickly because they go into severe spasm. So what do you do for that? I mean, what is this cuff leak test actually before you do the extubation in such patients?
Hello.
Yeah, can you hear me?
Yes, sir.
Yeah.
So
what
it's
is
about cuff leak test, sir.
Yeah, exactly.
You're muted, sir. Sharma ji.
Hello.
I think we all can be unmuted for the panel discussion. Maybe we don't have to keep on muting ourselves.
So you can, Dr. KK, can you hear me now?
I think there is some network issue. We can then move on to next question and come back to this question.
Yeah. So basically what is cuff flex? This is nothing but when you decide that this patient is ready for weaning and extubation, then you deflate the cuff completely and you should be able to see the leaking actually, which means the patient should be trying to speak and you should be able to hear the sound. If you don't hear the sound, which means that the balloon is virtually, the vocal cords are virtually lying above the above the balloon. And this means that there is probably swelling of the vocal cords, okay? And there is a chance that this patient may fail extubation. So the cuff leak test actually tells you whether there is laryngeal edema or not, okay? So Dr. Richa, what is difficult weaning? And, what diseases will you see this condition?
Okay. So as it was taken up in the presentation also by sir, so
Yeah.
difficult weaning is something when the patient initially fails his first SBT, and then the patient requires maybe up to 3 SBTs or maybe up to 3 SBTs or up to 7 days from the first initial assessment for the weaning. So that is difficult weaning. Anything beyond that is prolonged weaning. Now, coming to the second part, in which conditions we commonly see difficult to wean is, so a slide which was beautifully represented by sir was that any weaning failure, this basically requires balance between the drive, the central drive, the respiratory muscle strength, and what kind of load we are giving on that respiratory muscle. So whether it is elastic load or resistive load. So anything that causes an imbalance between these three factors can cause the weaning failure and make the patient difficult to wean. So we have going from the respiratory system that increases the resistive load when there is severe bronchoconstrictions, when there are secretions in the airways, in pneumonia or severe bronchospasm. These are the cases which can increase the resistance and again cause weaning failure. And so we see in severe COPD. Also, very commonly when we give high minute ventilation to the patient, that also leads to air trapping. So any increase in the elastic load also, which reduces the compliance, so any kind of atelectasis, pulmonary edema, which causes the alveolar thinning, that also can lead to the weaning failure. And then there are any kind of neuromuscular involvement, which can decrease the respiratory muscle strength. So diaphragmatic discussions we discussed at length that can lead to the difficult to wean patients. And in general, decrease in the respiratory muscle strength because of any kind of metabolic abnormalities, hypokalemia, hypocalcemia, phosphatemia, or low magnesium levels, or even nutrition deficiency. These can lead to low respiratory muscle strength. Even neurological conditions like decreased central drive, excessive use of sedatives, paralytic agents, and central sleep apnea, these can decrease the drive and then again make the patient difficult to wean. Also, conditions like psychological conditions where there is pain, delirium, agitation, because then we are caught up in that vicious cycle of giving sedation, giving neuromuscular blockers to the patient, and then again we are giving the trial. So we are caught up in that vicious cycle of going on and off. So that also makes the patient difficult to weaning. So if we address all these factors, then maybe we will be able to better manage the patients. And these are the commonly seen causes of the difficult to wean patients.
So basically, the longer it takes, difficult it becomes to wean the patient, mainly because of nutrition, critical care neuropathy, secretions, agitation of the patient, so many other things basically. So Dr. Khushro, what is prolonged weaning? Please elaborate that.
Yeah, so as Dr. Richa said, both these terms, difficult weaning and prolonged weaning, are used when there is a weaning failure. And difficult weaning it's just the time frame. So difficult weaning is up to 1 week and 3 failed trials. But anything beyond that and which reaches 21 days is called as prolonged failure. What happens between 1 and 3 weeks is, I don't know what term they would want to use. So there's a difficult weaning by definition up to 1 week, and 3 weeks and beyond is prolonged weaning. So what happens between 1 and 3 weeks? Having said that, I don't think we should follow the terminologies of difficult, prolonged, inappropriate, etc. But we should try to focus on why we are not able to wean this patient off and extubate this patient at the earliest. So Dr. Richa has given you all the possible criteria for that. But by and large, when you want to differentiate between difficult and prolonged is really, really a long one. One factor would be the disease that for which we are doing, we are trying to wean. So usually COPDs and asthmatics who have been on BiPAPs at home don't try. They are easy to ventilate, but they are very difficult to wean off, and therefore you might need other equipment like pressure support, like NIV, to extubate them from the TPs and put them on NIV immediately. So we call that extubate to NIV. We also need to look at the malnutrition factors. There is lots of hypophosphatemia and hypokalemia which might play a role. So we need to give adequate potassium correction. We need to treat the phosphates, etc., by oral route or by intravenous at times. We also need to look at one main factor, and that is critical care neuropathy and myopathy which develop. And most of these patients, if we have used neuromuscular blocking agents for ARDS, or they have been prolonged beyond 15 days, then they might develop this. So there are enough articles now how to circumvent this major problem of neuromuscular critical care neuropathy. And the only two factors which are useful and may prevent that is adequate nutrition with good proteins and very, very early mobilization. So even with the ventilator on, if the inotropes or the vasopressors are down to a reasonable level, we try to get them out of the bed once the vasopressors are off. So early mobilization, physiotherapy in bed from day one is the key to prevent these critical care neuropathies. Avoid steroids, but that's easier said than done. And so prolonged weaning is a bad thing. And many a times we may need to resort to a tracheostomy in these patients and then to wean them off. So I think we need to understand the severity of the disease for which we have ventilated them. We need to understand the chronicity of the disease like a COPD, etc. And we then also need to look at the other causes which we have probably added on to in the ICU in the course of the ventilation.
So Dr. Krishav, one of the common things which you see in the ICU is use of paralytic agents actually and sedation. So is there a difference between giving paralytic agents on an SOS basis rather than giving it continuously? Would that help in weaning the person?
Yeah, that's a very, very important question. So every day in the VAP bundle and in the weaning bundle, we need to have a sedation holiday. So let's talk about sedation first. So we call it a sedation holiday, and we must assess the neurology of the patient on a daily basis unless they are unstable and not ready for weaning. So we give a 1 hour sedation holiday and we assess them neurologically and in other ways too. About paralytics, we avoid as far as possible in our ICU, but there is only little literature on the use of it in the ARDS, which are not getting ventilated and oxygenated. So I would probably use a drip. And if I'm using a paralytic agent, then I would not use it SOS. I would have to give it as a drip for 24, 48 hours and buy time till the oxygenation improves. And once that is better, I will wean the or absolutely cold turkey and stop the paralytics throughout. If I'm giving paralytics on a regular basis or an infusion basis, I will always do a train of 4. This is a very nice test which the anesthetists do. It's a train of 4. which assesses your neuromuscular junction. So 50 milliamperes is given on the two electrodes placed on the ulnar surface, and they give a current of 50 joules, and that should actually get your thumb moving 4 times. So there are 4 impulses and 4 movements. When you give a paralytic, you try to keep it 1 to 2. So out of the 4 impulses, only 2 should transfer or 1 should transfer, and that would mean that your paralytics are adequate. If it's 0, it's too much, and if it is 4, it is inadequate. So whatever we do, we need to monitor.
Sure. Thank you, Dr. Krishav. Can I come to Dr. K.K. Sharma now to summarize what would you do to help weaning in such difficult cases? Can you just summarize that? Dr. K.K. Sharma?
Lost him, I think.
He's not available.
He's not there.
Okay. So like Dr. Kushner said, the most important thing would be to make sure that in such difficult cases, sedation holidays, removal of paralytic agents, early mobilization of the patient, nutrition, and everything. All of these things are going to help. But obviously, the first and foremost important thing would be to reverse the condition for which the patient was being ventilated. So, Dr. Richa, when these patients need to be extubated, we've seen in COVID time that some of the patients actually were very difficult to extubate, and we actually did HFNOs trials. So, have you done that, and how does it help actually? And are there any particular conditions where HFNO will help?
Yes, yes, sir. So yes, COVID was one of the condition where we quite frequently use HFNC, and HFNO also. See, when we talk about improving oxygenation after extubation, so either we can give the oxygen therapy, the conventional oxygen therapy, we can use a HFNO, or maybe we can use a NIV, which is now very many. NIV is a well-established extubating to NIV. But HFNC has some advantages over these two modalities. One is the better humidification. You can give higher flows, so we can actually meet the patient's inspiratory demands. We can have better saturations, lesser desaturation with the same amount of FiO2 because of the high flow and less entrainment of the air inside. Then there is comfort definitely better than NIV because the patient can speak, patient can have oral feeds, and you can manage the secretions better. So, and humidification also is a bigger advantage when we are actually suspecting upper airway obstruction or edema. So these things definitely they are positive for HFNC. And coming to the next part, that where I would like to use HFNC after extubating the patient, then acute hypoxemic respiratory failure patients, specifically if because it can give small amount of PEEP, then in cardiogenic pulmonary edema also for the recruitment, and any kind of acute hypoxemic respiratory failure, even in COPD patients, if they are not chronic hypercapnic or if they are not in hypercapnic respiratory failure, then definitely because PEEP will overcome the intrinsic PEEP. So there I can use and reduce the work of breathing also. And any other condition, pneumonias also, as we discussed, COVID-19 pneumonia, we all will agree that we have used HFNO. So pneumonia is one condition where I can extubate to HFNC. And sometimes when we are using extubate to NIV with intermittent HFNC also, I use that. Maybe if I'm trying to wean from NIV also, then it will be NIV with HFNC and giving overnight NIV and then at the daytime HFNC. And which is very well now in the evidence also, using HFNC with NIV. There are recent RCT, which has shown that it actually works better than NIV in high-risk patients. So any high-risk patient where I'm expecting an extubation failure, any major underlying chronic lung condition, or even cardiac conditions, LV dysfunction or heart failure, and elderly patients where I'm expecting that there is a high risk chances of extubation failure, is somewhere where I'll consider HFNO as extubating to HFNO.
So would it be fair to say that HFNO user patients would be mainly hypoxic? They are otherwise ready to be extubated. It's mainly because of hypoxia. They're not ready for extubation.
Yes.
Would you say that? Yeah.
Yes.
Okay.
And work of breathing also.
And work of breathing.
Yes.
So Dr. Kushra, what about the NIV in such situation? I mean, we used NIV in COVID patients many a times. And would there be some kind of NIV weaning as well in such patients?
So before the COVID times, at least the last 10, 15 years, we've been extubating to NIV directly. So we extubate and don't even put them on oxygen. We directly put
Will
them
that
on
be
an
mainly
NIV.
COPD patients? Will that be
Yes.
mainly
So,
COPD?
I was
Exactly.
just coming to that very important point. So
Yeah.
there's lots and lots of literature, as Dr. Richa said, that HFNO is much better than NIV in weaning patients off. But that's the group of patients, as Dr. Bansal, you mentioned, the hypoxemic ones. So acute hypoxemic patients, HFNO does extremely well. But those
Yeah.
patients, if we do an ABG and the CO2 is high, or they've been COPDs who've been on BiPAP before, or they are Guillain-Barré and the CO2 is a little on the higher side, the hypercapnic patients will not benefit from a high frequency a high flow nasal oxygenation, and they will need NIV. So this select group of patients would need extubation to NIV rather than extubation to. So a simple rule of thumb, as discussed by everybody, was that hypoxemic patients, maybe the difficult ones, extubate to HFNO, and the hypercarbic ones with increased work of breathing, with diaphragmatic weakness, with a long-standing critical care neuropathy, I would extubate to NIV.
Yeah. Thank you, Dr. Kashyap. So there comes a time.
So before the COVID times, we had only 2 HFNO machines, and now we have 20. So it just shows how much we use it and we rely on that. So HFNO has really changed the picture in.
I think the only problem with the HFNO machines were that it was using very high flow oxygen, which means that unless you had a good oxygen supply, it's going to be very difficult to use them. And many hospitals actually during the COVID time also failed because of that reason.
Yeah.
And there was also reason of exposure of the fumes, basically, which was happening all the time. So, it was not really advisable unless you had surrounded the patient with some tentage or something like that, basically, to isolate them.
Absolutely.
So, Dr. Prabhudesai, obviously, some of the patients you will find it still very, very difficult to extubate. And we all know that tracheostomy actually helps these patients. So what is the timing of tracheostomy, Dr. Prabhudesai, in such patients? How many days would you do an early tracheostomy in some patients, or would you do a late tracheostomy in some patients? Dr. Prabhudesai?
Yeah, I think it's very important to know what is the reason for intubation of the patient.
Yeah.
So if you, at the time of intubation, you will have an idea approximately how many days this patient is going to be on mechanical ventilator. Okay, and then sometime even if you have say Guillain-Barré syndrome which is developing, and that this is progressive and you are putting on intubation and ventilation, there is no point in waiting on ventilator, putting on a ventilator on keeping a tube inside. I prefer to do an early tracheostomy. If suppose patient is having a severe trauma and he has head injury, etc., and all that, he is going for a surgery in the theater for that, I would prefer to do a tracheostomy at that time.
I think most of the neurosurgeons actually do that most of the time during the surgery.
So the reason for intubation decides when to do a tracheostomy. Second is that if the patients require a lot of sedation, that if you remove the sedation, he is not patient comfortable.
Absolutely. Yeah.
So I think for that is also a reason for some time to consider for a tracheostomy. Third is that you are given a repeated weaning trials. Okay, or I will say that even 2 extubation trials you have done and one failed. Second time intubation, second intubation failure means most likely you will land up with tracheostomy. And during second intubation, the person who is intubating will say there is a laryngeal edema and all those things. If you see and if you suspect stridor happening on the first extubation, after extubation, why unnecessary, waste time and give a second extubation trial? So these are the common reasons which we should observe and then take a call on tracheostomy. Obviously, if patient requires a prolonged intubation, secretions are plenty, in the respiratory system, I will prefer to do a tracheostomy. But generally, say around in 8 to 10 days ventilator, I will prefer a tracheostomy because we have very good control over the airways with tracheostomy. And unless there is his parameters for complications are unlikely to happen on tracheostomy. Like he's on a lot of antiplatelets, heparin, and all those things. His bleeding time, clotting time factor. He's a liver failure patient who has got an INR. So then obviously we have to be very careful in taking a decision of tracheostomy. We'll probably try to correct all those things and may little prolong intubation in such patient and give a trial. So I think these judgments are done on like that, but weaning failure is an important reason for tracheostomy, you can say.
Tell me one thing. There is a patient who would day 10 still requiring inotropic support, which is 8 to 10 microns of NORAD. Would you do a tracheostomy in such a patient?
Say, I can tell you that yes, just the inotrope support is required. Okay, I don't think that is but otherwise hemodynamics is blood pressure control. It doesn't have arrhythmias. I will go ahead with the tracheostomy. I don't think that's the only parameter on which tracheostomy cannot be done. But but patient is intubated and ventilated for a prolonged period of time and he is not getting coming out of the ventilator and his sepsis is not getting controlled. Okay.
Yeah.
Then I will not wait for I will do a tracheostomy.
Yeah. Thank you, Dr. Professor Sai. So there are actually important factors like critical care neuropathy, which causes weaning failure. Dr. Sumita, what can you do to get this critical care neuropathy better, or probably prevent it altogether?
Right. So, critical care neuropathy, as discussed in the earlier presentation, also is a very common cause for weaning failure. And it is again a very common complication that we see in the ICU. So, if the patient is there for like 7 days in the ICU, more than 25% of this patient will land up into critical care neuropathy. And the most common cause that we see is because of severe sepsis. The inflammatory response syndrome itself is responsible for causing this kind of neuropathies. Earlier use of excessive amount of neuromuscular blocking agents have been also shown to predispose these patients to muscular neuropathy. Some studies have shown use of glucocorticoids, and main triggering factors are your high severity index, high illness of the patient, associated with hyperglycemia, hypothyroidism, multi-organ failure. So this cause list is important to understand what you would do to prevent critical illness neuropathy and to treat critical illness neuropathy, both of the things. And first of all, most important is if you can prevent it, not let it happen itself. So by minimizing the use of neuromuscular blocking agents, as said, giving sedation hold every day, early mobilization of these patients, seeing to it that the nutrition part is taken care of, even though patient is like on ventilator, on RT feeds, but the nutrition part is still taken care of. And then if to manage once the critical illness neuropathy has happened, again, managing it is it's really like a nightmare for the intensivist once that happens. So what we need to do is treat the medical condition as early as possible. So like if the patient is out of sepsis, out of its renal failure, those kind of things will help in early healing of those neuromuscular neuropathies that has happened, the weakness that has happened, preventing of further complications. So preventing of further infection happening to these patients, prevention of DVT, those kind of complications need to be prevented so that further neuropathy is not developed in these patients. And as I said, even though these patients have developed a neuropathy or a myopathy, still trying to early mobilize them. And that is the only factor that is really going to work for these patients is early mobilization, again, minimizing sedation, and then glucose control is very important in these patients. So targeting a glucose of 80 to 110 has been shown to improve these kind of neuropathies and myopathies. Even prevention is there. Stop glucocorticoids if you're using, if not required for these patients. If required, then again monitor for infection, monitor for hyperglycemia. As I already mentioned, again, taking care of nutrition support. And in some institutes, I think neuromuscular electrical stimulation has been tried in these kind of cases. So, but that's not really available, I think, widely everywhere. But there it is that this can be tried in those kind of patients. So, yeah, these are all the factors that we can do to prevent and treat critical illness, neuropathy, and myopathy. Right?
Yeah. So I think it has, Dr. Khusrav, can I just ask you, it has already been mentioned that nutrition and early physiotherapy is really important for weaning such patients. Would you just like to elaborate in a few lines?
Sir, I think Dr. Sumita has said it all, but we like to give at least 1.5 grams per kg of proteins per day.
Yeah.
And it's not important. We as doctors love to look at the ventilator parameters, the hemodynamics, the urine output, the renal the cerebral, but we often forget that nutrition is also a system. It's a GI system. And if we don't pay attention to the nutrition, we are definitely having a problem. Weaning itself does not mean that we stop feeding the patient. Only when we are planning to extubate them, then we would do that. And when we are reasonably sure, like a post-operative patient whom we are going to put on TPs and extubate, there we can keep them NBM for at least 2 hours before the extubation trial. Having said that, we may just write some feeds and we'll come off from our rounds. But it's very imperative for us to understand and write what is, as a prescription, like an antibiotic, you should write these many calories, these many ml, this much should be the protein calorie ratio, decrease in the carbohydrates if there is a COPD, etc., and so on and so forth. Having written that, we must also look at the RT aspirate. We must also look at whether the patient got all that in the next day. So what we do is we have a team effort where we talk to the nurses, we talk to the dietitian, we ask them to not only write down what we have to give the patient what we have written, but also to tell how much calories was given before that. So I think
is there any role of micronutrients in such patients?
Right, so that's a very important point. We all seem to have missed on that. Unfortunately, we didn't have much of micronutrients available to give a critically ill patient. There are lots of other products available on Amazon, etc., but we don't use those for our patients. And yes, now there are micronutrients available. Phosphates need to be treated. Electrolytes need to be kept appropriate. And there are micronutrients like selenium, zinc, chromium, which are available in some multivitamins, and we always put them on that. And early mobilization. So we have seen and do. We take patients on a wheelchair with a ventilator across. It's very labor intensive. We need 2 intensivists, 2 nurses, 1 respiratory therapist, 1 housekeeping person to actually, it's like a band baja, and we take the patient around.
It works very well.
But it really works, sir. Psychologically,
it really works.
Yes.
So, Dr. Richa, when you weaning the person, is there any difference between weaning a COPD patient versus weaning an ARDS patient?
So, in terms of pathophysiology only, that COPD is a chronic lung condition and with some acute condition that the patient has come with. And then ARDS is an acute inflammatory condition. And if we see in COPD, there is issue of resistance, and then there is an issue of compliance also. And usually it's a high lung compliance because of the emphysema part. Whereas in the ARDS, there is low lung compliance because of the collapse and the differential alveolar de-recruitment and all. So there is a major difference. So when weaning in COPD, my major concern is about the autopeep that tends to develop in these patients when weaning. So looking at the graphs to detect autopeep early and managing it accordingly. And also for decreasing the resistance when it comes even from the ventilator circuit, like looking for any kind of mist or the secretions in the circuit, in the tube, if there are the excessive secretions are there, kinking of the tube, the elbow-shaped parts of the various ventilator circuits, so which anything that can increase the resistance and overall cause more impedance in the weaning. And then definitely managing the bronchoconstriction part, the bronchospasm part in the COPD, and managing the autopeep with a good amount of extrinsic PEEP that we are applying. So extrinsic PEEP is very important in when weaning the COPD patients, and what minute ventilation we are targeting, because a higher minute ventilation will actually eventually lead to air trapping, more dynamic hyperinflation, and more autopeep. So that is something we need to target, that 6 to 8 ml per kg of the tidal volume, and a respiratory rate that is settled below, target is below 20, that we target the respiratory rate to be below 20. So that is when COPD, and maybe also when weaning, then one thing on my mind is that I can extubate to NIV also. Whereas in ARDS, we are looking at alveolar recruitment, and there is a major problem of asynchrony, the ventilator dysynchrony, and I'm trying to minimize that when weaning, because there is a major concern of patient self-inflicted lung injury, so which is there in ARDS, which is always a problem in ARDS. So when managing the ventilator asynchrony is of prime importance, and thereby choosing the mode accordingly. And as Dr. Sumita highlighted and ma'am highlighted, there are various modes, so always switching between the modes to minimize the drive, to minimize the respiratory drive, and to keep it so that we are not over ventilating also and we are not under ventilating also. So minimizing synchrony is very important when ARDS. So they are two very different conditions.
So if I were to give you a scenario, a patient of COPD who was using home NIV therapy at a pressure of 1610, comes to the hospital, gets ventilated, and now is ready for weaning. So would you wait for this guy to give a TPs or spontaneous breathing trial, or would you straight away go on to extubate and put him on bilevel ventilation?
So I will extubate to NIV. On my mind will always be extubate to NIV, and I will, for this patient, I will definitely give pressure support ventilation rather than the TPs.
Absolutely.
So I will not be going in maybe at the baseline pressure. And also, when I'm weaning, I will not consider it a failure. I will try to target the baseline CO2, which was before.
Absolutely.
And not really 35 to 45 is what.
Exactly. So it's very important to realize
NIV,
what was
right?
The
baseline was
NIV,
on NIV, so we cannot expect a better baseline than that.
Absolutely. So that's very important to know what was the baseline of the patient. So Dr. Khusrav, can I just ask you a final question?
Yes,
this is a repetition. We need to know this very clearly. So what is rapid shallow breathing index? Because it seems to be the most important index to try and wean the patient. Would you just elaborate on this?
Yeah. So when we decide to wean somebody, we have our respiratory therapists, and we also stand by and we disconnect the ventilator. We keep the ventilator connected, but we put pressure support on 0, and we are trying to look at the patient's mechanics. So rapid shallow breathing index is nothing but a division of the respiratory rate and the tidal volume. So if that is by books, it is less than 105, then the chances of success are more. I'll just explain very easily. Instead of this number 105, let's take an example of respiratory rate being 30. The patient is tachypnic. But if the tidal volume is 10 times more than the respiratory rate, so this patient draws a tidal volume of say 400, then the chances of success are going to be higher. But at the same rate of 30, he is tachypnic, he or she is tachypnic, but the tidal volume is only 250. Then it is not 10 times the respiratory rate, and then the chances of failing will be higher. So I think this is a very important respiratory mechanics, which we see as a rapid shallow breathing index.
Yeah, thank you, Dr. Khusrav. So there are a few questions from the participants, and one of the very interesting question is, Dr. Khusrav, you can answer that. What is the ideal mode of weaning in COPD with pneumothorax with ICD in situ in such a patient? With bronchopleural fistula. So he's given a complex situation, patient on ICD, bronchopleural fistula, pneumothorax, COPD patient.
So I would have tried my best to wean the patient off from COPD before a pneumothorax was happened.
Yeah.
And if the pneumothorax happened, I would put the ICD and again try to wean early, because the more positive pressure that we give the patient, the more the chances of bronchopleural fistula. So I would not link weaning to the development of BPF, but I would, once it has developed, then I would probably involve a thoracic surgeon and get a VATS done and try to close the bronchopleural fistula. Otherwise, even weaning them on NIV is going to be extremely dangerous. So this patient does not need weaning, but this patient needs more therapy. Yeah, Dr. Prabhu has a point.
Yeah. I had recently a patient. I muted. No, I had recently a patient, interstitial lung disease with cystic lung, and he developed a pneumothorax. ICD was put. He was on mechanical ventilator. What we tried over there is that obviously high flow nasal oxygenation really works there, and we could extubate the patient and put back on him in high flow nasal oxygenation. And we were successful in preventing that further pneumothorax. And even later on, we did a pleurodesis. So I think this high flow nasal oxygen is really useful when pneumothorax with obviously some other criteria are you are ready to accept it and take a bold decision of early extubation and putting on this.
That's before the bronchopleural has developed. So pneumothorax, yes,
So
but
once
if
the one
BPF
BPF is there and pneumothorax is there and tube is there, still, the constantly the positive pressure mechanical ventilation, the pneumothorax is going to in ILD. There is a very little balance, so we have to do in a very early investigation, remove the mechanical ventilator, and even
So
NIV also causes pneumothorax in ILDs.
Yeah, sure. So another interesting question from Surinder Kumar from Punjab Sangrur. While trying to do the extubation, can the TP's trial be bypassed? Dr. Prabhudas,
Yes.
can you bypass the TP's? I mean, just take out the tube.
Yeah, I mean, a post-op patient, Dr. Kushrao has already told us in this patient
Exactly.
we don't require a TP trial. You can just
So
once
healthy patients, it is very easy actually to decide.
Yeah.
But patients who've been chronically ventilated for a longer period, maybe you would not like to do that.
No, absolutely not.
Yeah. So
having said that, at least 10-15 minutes of observation on a TPs, even for a post-operative patient, is necessary, because overnight, for example, a CABG patient. So a CABG patient would be on sedation, would be on painkillers, and then we suddenly wake them up by stopping the sedation 2 hours before. We are not very sure that they are ready or not. So completely bypassing may not be appropriate, but at least a 15-minute trial, and you may not do an ABG. You might just look at the patient at the bedside. But you can do that.
But I think like Dr. Prabhudasai said, surgical patients who've just been operated for 30-40 minutes, but I don't think we are talking about such patients in any case here. Okay, another interesting point I think it has been discussed is from Surinder Banerjee from West Bengal, who says, can we apply HFNO to hypercapnic, hypoxemic patients? Obviously, we can, and it has been discussed. And also, Rida from Maharashtra, Mumbai, should the patient be put on half an hour to 1 hour on volume control trial before extubation? I'm not sure as to what she is trying to say, because normally we do not do this. How to understand by ABG that we are over-ventilating the patient?
No, there are two questions. One, I think this volume control thing has come up from a trial, which they say that you have done a TPs. Now the patient is ready to be extubated, but they have done this 1 hour of TPs and they're tired. So you can reventilate them. It is called the reventilate trial. And in that, you reventilate them for half an hour or 1 hour, give them rest, and then directly take the extubate them. So this may be a concept. We don't follow that. Yeah, that's right.
Okay, there's another question by Dr. Satish from Kerala, Thrissur. How to understand by ABG that we are over-ventilating the patient?
So there will be CO2 which will be washed out.
CO2 which gets washed out. I think that should be. So I think that's about all the questions we've taken so far. I think it's been very, very interesting discussion. I can summarize by saying that weaning is something which is, which should be tested by seeing the readiness of the patient, and then slowly decreasing the ventilator support, and then finally extubation. And obviously what helps is to make sure that the condition for which the patient was ventilated has been reversed, and you have made sure that the most of the parameters are doing well. You can do multiple modes of trial of weaning by either spontaneous breathing trial or PSV or PAV, depending on what the situation is. But the ultimate aim is to actually get the patient off the ventilator. In case you're not, then tracheostomy remains one of the very important tools to wean off such patients. If there are any further questions, then we can take them. Otherwise, I think it's been a very good discussion.
Have you heard about a transvenous diaphragmatic pacing for difficult weaning?
I have not done this, nor have I heard about it. But if you have, you would like to know.
Indian doctor is actually.
Sumita mentioned that. Yeah, so you can do diaphragmatic pacing. So actually, since you brought this point out, POCUS, which we do an ultrasound at the bedside, we look for any B line so that whether the patient is wet or not, and we can give a diuretic before extubation. And we also look at the diaphragmatic excursion. Not a very easy thing for non-radiologists, but we can actually look at the excursion on a T-piece. And if that is poor, then those are the candidates for diaphragmatic pacing or nerve stimulation. And Dr. Bansal, you beautifully summarized the entire 1.5 hours. Thank you.
Thank you so much. If there are no more questions, then I think we would like to wind up this session. It's been wonderful having all of you. I would like to thank Dr. Khusrav, Dr. Amita Nene, Dr. Richa, Dr. KK, Dr. Sumita, Dr. Prabhu Desai for their wonderful participation. And obviously, without Sipla's help, who has been instrumental in bringing the series, this would not have been possible. And obviously, thanks again to the CSI people actually who've been instrumental in organizing this web series. Thank you so much. We'll wind it up.
Thank you so much.
Very
Good
much.
night.
Very
Yeah.
stimulating discussion.
Yeah.
Thank you.
Sure. Thank